Thank you so much. I really appreciate the invitation, and I'm excited to talk to you all today. And glad to see a couple of Canadians here. I was born in Canada, but I've been here for 26 years. So you could call me 50% Canadian, 50% American at this point, because it's about 50-50 time spent. But I'm really glad to be able to talk to you. And so the way I set up this lecture is really, I'm going to try to get through the presentation within 45 minutes, or maybe just this in and around that time frame. This is basically my grand rounds lecture I gave at Cornell, Mount Sinai, Montefiore Hospital. I've been doing grand rounds all over the place now that COVID's opened up, because this is really the deep science of SIBO and IBS. And so I'm glad to share this with you, but I have a couple of secrets for you. I have some new papers that just got published in the last week or two. So for the first time, you're going to see those before anybody else, because they just came out. So it'll be fun to give you a sneak peek of some of the new stuff. But what I want to do is take you on a bit of a journey, but first talk a little bit about this program. What is the MAST program? So it's about 10 years in the making here at Cedars before it finally formed about 3 years ago. And we see the patients, we know what the patients need, we know the microbiome, and we're very excited about studying the microbiome in the context of human conditions and to develop things here, because sometimes pharmaceutical companies have their own idea of what will sell or what will be important for patients. But I think as physicians and physician scientists, we know what will work potentially. And so we've been really trying to develop the next generation of treatments along the line of the microbiome. But let me go back, and I'm not dating 1996 specifically because that's when I started fellowship, but that is the time where this was pertinent. Irritable bowel syndrome at the time was a diagnosis of exclusion, if you see in the middle here, meaning you have a patient who you don't know what's going on, and you apply criteria. You have to have abdominal pain, you have to have diarrhea or constipation, you have to have bloating, you have to have these kinds of symptoms. So IBS was diagnosed based on criteria, which the problem with the criteria, even today, the same criteria with some modifications from those first criteria. Crohn's meets the IBS criteria, celiac meets the IBS criteria, so they're non-specific. They mean nothing. They're just basically you have to have those symptoms. But we didn't know what was going on with IBS then. Tradition has it, if you don't know what's going on with a patient, it must be stress, anxiety, depression, all these different things. And the worst part is that women had IBS more than other patients. And so back in those days, and this is the sad part, is that they call it a women's disease because women get more anxiety, or maybe it's related to the menstrual cycles, and all these kinds of things were the thinking of the 1990s. Shamefully, the quote on the bottom was from 2018, just a few years ago, which is ridiculous considering all the science I'm going to show you today. We knew much of it by 2018. And to say that is shameful. But going on the right side, and then this is what I want to emphasize, is because you don't understand what's going on, you treat the symptoms. So it's like you have a bruise or a cut on your skin and you put a Band-Aid on it. The cut's still there. You're just covering it up. And symptom approaches. Can you imagine a guideline for Crohn's disease where the first line therapy is Imodium? It's not gonna happen. Doesn't happen. You don't see Imodium, that word, in a Crohn's guideline at all, because you don't treat the symptom, you treat the cause. So that's what I want you to start you with, is that was where we were, but we're not there now. The second thing is the Rome criteria really ignored bloating. And there's now 2 papers literally in the last couple of months, one in clinical gastrointestinal, saying if you take bloating in general, IBS and bloating are intimately linked. And then if you look at the Rome Foundation study, so this is Rome, these are the people who make the criteria. Bloating and IBS are linked. These 2 trials are really important. And then if you go to the practical update, and this is the Rome people, Baha Mosheri, Doug Drossman, and Ozma Shakut. These are the Rome people. They say, if you want to work up bloating, you better look for carbohydrate intolerances and do carbohydrate intolerance testing. I'll talk a little bit about that at the end. And you should be doing SIBO breath testing as part of your workup. This just came out in this fall. We're going to cover all of this, but I want you to get this sort of understanding that this is front and center in the high-end literature. Gastro is the top journal in gastroenterology. But I'm going to cover this. And if any of you have ever heard me speak, you've probably seen some of these slides because this algorithm or this pathway has not changed. But I gave a lecture yesterday and people were just surprised at how concrete the evidence is now for this pathway, that food poisoning starts the whole thing. The CdtB or this toxin is the ingredient in food poisoning that triggers autoimmunity to vinculin. And that autoimmunity to vinculin, the antibody to vinculin, reacts with the nerves of the gut, leading to changes in the function of the small bowel particularly, and you get bacterial overgrowth. And I'm going to cover this whole scenario. But let's go to the bookends first. Does food poisoning, E. coli, Campylobacter, Shigella, Salmonella, does it cause irritable bowel syndrome? This is the best study. This is a Mayo Clinic study. It hasn't been another meta-analysis, but it's pretty concrete now. So food poisoning causes IBS, full stop. And if 100 people went to a wedding and the buffet was contaminated and 100 people got salmonella, the problem is 1 in 9 or 11% of those people will develop IBS for an indefinite period of time after that. And so while this is a big thing, because when you think about irritable bowel syndrome, compared to Crohn's and ulcerative colitis, where billions of dollars have been spent trying to understand Crohn's and ulcerative colitis, there's no smoking gun for Crohn's or else. Why does Crohn's suddenly pop up at 20 in a 23-year-old male? We don't know. And we have ideas on how to treat it, but we don't know why. We know why IBS forms. It's food poisoning. It's the trigger or tripwire. That helps a lot because it allows us to understand why that happens. And so we'll continue on the journey here and I'll show you some of that. So the next question is, we see an overlap between IBS and bacterial overgrowth, which I'll cover more detail later. We see that overlap. But does food poisoning, if food poisoning causes IBS, could it also cause the overgrowth that we see as an overlap of IBS? And the answer, we answered this in 2008, but we've come way further than this. I'll show you in terms of sophistication and understanding this. But the first study is really important because it's the first time in history we had an animal model of post-infectious IBS using Campylobacter, which is the #1 cause of food poisoning in the US in humans. These rats got Campylobacter jejuni, these didn't. They recovered from the Campy after about a month, then 3 more months, total of 4 months. We studied them, and then we looked at whether they developed weird bowel habits like IBS, because we don't have a questionnaire that rats can fill out. And then we studied their gut segments. Turns out they got Campylobacter. 27% of these rats now have SIBO based on more primitive microbiology, qPCR, back in 2008. So now we do sequencing, and I'll show you some of that later. But what else they had is that if you look at the purple column, which is C plus means they got Campylobacter, SIBO plus means they got Campylobacter and they developed SIBO. In the rats that developed SIBO, 84% of them had weird stool patterns like IBS. They also had increased rectal lymphocytes, which is the only thing that has ever been found in humans with post-infectious IBS. So we have the first animal model of post-infectious IBS. So it gave us an opportunity to really dig in and find out what's going on. But I'm going to show you some of the details, but I want to fast forward to 2022. There's an old postulate called Koch's postulate. Koch's postulate and it was studied, for example, in tuberculosis and other diseases. How do you prove that a bacteria is causing a disease? And that's Koch's postulates. But Bradford Hill criteria is Koch's postulates on steroids. So does Campylobacter cause IBS on steroids? And the answer is it meets all the criteria. So we now know in 2022, based on all the data I'll show you here momentarily, it's cause and effect. So IBS is caused by this. But how does this happen? So let's focus on this CdtB toxin. The next thing we did was we said E. coli, Campylobacter, Salmonella, and Shigella, they all have different morphologies. You can see how they look. They look different. They have different genes, and they have different toxins. But there's one toxin they all have in common, and that's CdtB. We took an interest in CdtB very early on because it was the one unifying factor or toxin, if you want to call it. And so we actually repeated the Campylobacter experiment, but we deleted this toxin. So no CdtB toxin in this Campylobacter, and the rats did not develop IBS in the same way. So we knew that CdtB was important. But what CdtB does when you get exposed to is it makes you form antibodies to a protein called vinculin. So I want to introduce vinculin a little bit before we get into this. These are cells in our lab, and you can see that these green filaments are actin. Actin is your skeleton, or like the scaffolding of your cell to keep the cell shape. And the red on the tips, you can see little red lines right at the end of the actin, and very nicely shown here. Vinculin acts as part of a complex or a focal adhesion plaque. It's called like a motor at the end of actin, like a corkscrew, pulling the cell tendrils out to grab onto the next cell, like the wires in your house system, where the wire connects to the next junction box or to your light switch. So this is the wiring between cells, especially nerve cells. What we quickly learned is that the cells that, for example, are important for the cleaning waves of the gut, this is called the deep muscular plexus interstitial cells of Cajal. In IBS patients, so they are decreased, and I'll show you that, but Campylobacter is here and SIBO is here. And so these rats that we did initially, when we looked at the cells that make the cleaning waves of the gut, they are reduced in the Campylobacter SIBO group. So it turns out that in humans, we also see a reduction of the migrating motor complex. So less migrating motor complexes or cleaning waves of the gut. I know some of you may not be familiar with migrating motor complexes, but migrating motor complexes are the sound you hear when you're first thing in the morning, you haven't eaten. It's a gurgling sound, and you're very embarrassed because you're in a classroom or you're in a quiet space and everybody can hear your stomach. Do not be embarrassed. This is the most important thing you have at night to clean up the debris from last night's dinner. So your bowel is like a dishwasher clean, and it gets rid of bacteria as well. So you need this. If you don't have it, you get small intestinal overgrowth, and we've known that since 1977. So no cleaning waves or low cleaning waves, overgrowth happens. So back to this CdtB toxin, what we then did was we said, okay, so if CdtB toxin is the culprit, then you don't need Campylobacter. You just need CdtB. So we did an experiment, and we injected rats into their skin of their back, like a vaccine, like a COVID vaccine, basically. Just CdtB toxin. And then 3 weeks later, we gave them a booster, just like your COVID vaccine. And of course, they didn't have CdtB antibodies in their blood before. But now, just like you have COVID antibodies from the vaccine, they have antibodies to CdtB. But look what else they developed. They developed antibodies to Vinculin. Just by giving CdtB, the rats began to produce anti-Vinculin antibodies. Not just that. When we then looked at their small bowel, this is the duodenum, this is the ileum, they developed overgrowth of small intestinal bacterial overgrowth. And they had less Vinculin in their gut because this antibody was mopping it up or getting rid of it. This was super important and suggesting the real culprit is not the food poisoning, it's just CdtB. So we think it works like this now. No, I'm skipping probably 10 or 20 papers because we just only have 45 minutes to get into this. We could spend probably an hour to two just on CdtB. But basically, you get exposed to this toxin when you get food poisoning, and you don't like any of it. This is not you. CdtB is not a human protein. You don't like this part, you don't like this part, and you don't like this part. Problem is, this part looks a little, and that's called mimicry. So the CdtB has mimicked you to make you form antibodies to you, and in this case, the human vinculin protein. So this paper I can announce today, actually, so new, hot off the press. This paper is in press at Gut Microbes, a very prolific journal. So we're very excited about that, and it probably will be released. So we've presented at DDW, so it's public information already. but but we're going to be announcing the paper probably in a day or two. We've already finished the proofs. But we did the same experiment over, but now we're getting even deeper. So again, CdTB, more antibody. What we see in the rats, they get a higher stool wet weight, and the higher the CdTB antibody, the more wet the stool is. But then in this study, we did the microbiome. What I want to emphasize with you is that because it's a funny thing for IBS research, because stool comes out of the rectum, you assume the problem is the colon. So if you have diarrhea, you assume, oh, the colon is not working right. But that's not what's happening at all. You can see the microbiome between the control group and the CdTB group and cecum and stool. There's no difference. Everything is happening in the small bowel, as we've been showing all along. There's big differences in the small bowel. And in fact, what happens in these rats, to cut to the chase, is that let's look at the control rats first. They didn't get CdTB. They're just control rats. Their bowels are normal. And you can see here that their microbiome sits here in these orange clusters. So just going to the wedding where everybody got salmonella, some of the people, or some of the rats in this case, green, they don't change. They're still fine. They got the CdTB. They didn't develop IBS. But the groups that did, they don't develop IBS in a uniform way from the point of view of the microbiome. They break into two microtypes. One microtype is E. coli, and that's this microtype. And E. coli is a hydrogen producer. The second microtype is desulfovibrio, which is elevated in this cluster. And we know desulfovibrio is the hydrogen sulfide cluster. So I want you to remember this, because this is the story of diarrhea IBS. And I can tell you the story of diarrhea IBS in humans is this exact two clusters. I'll show you that later. And we also showed in this study, which is part of this paper at a poster at DDW, is that the CdTB toxin creates a situation in your gut where your gut's permeability has changed, where your gut is now hypersensitive to pain, and where you have all sorts of changes in secretion and even circadian rhythm. So I don't want to get too deep in the weeds, but there's a lot of different things that are happening as a result of that. And certainly motility factors are being affected by this CdTB toxin and the consequential change in the microbiome. Okay, so now can we use CdTB as a diagnostic test, this antibody? Let me go back one step. We developed the blood test for anti-CdTB and anti-Vinculin. And it worked. It showed that if you measured anti-CdTB or anti-Vinculin, you could diagnose irritable bowel syndrome as compared to Crohn's disease or celiac disease. The problem is these proteins are very funny, and funny meaning they are very sensitive to the conditions in the plate. So we had to develop a second generation test, which is now the IBS Smart test, because it allowed the protein, we call it epitope optimization, to allow the antibodies in your blood, when they see the protein, to react better. And then that separated the groups. So the only test on the market that has the second generation results and that you can use this paper is IBS Smart, because this is the second generation test with epitope optimization and better separation from Crohn's and ulcerative colitis. And the technique for getting that epitope optimization is part of the trade secret at Gemelli, because we don't want people to understand that as yet. But because it's really important, these proteins are very finicky. As you can see, anti-CdTB, very different than Crohn's and ulcerative colitis. Anti-Vinculin, even better separation. And what happens is when you look at the post-test probability, if anti-CdTB is positive or anti-Vinculin positive, it's over 80%. But if you go to both positive, it's 98%. But the most important factor is this likelihood ratio. And I want to talk to you about this. So medical certainty is when the post-test probability of a marker is 80% or higher. That's medical certainty. So let's talk about any test that's ever been developed in irritable bowel syndrome. So there was a pain perception test, and I'm not going to detail all of these. I'm just going to go through. There was a 34 biomarker panel, not on the market. It had a post-test probability of 74%, bile acids in stool 78%. There was a 10 biomarker panel, not on the market, 79%. There's a visceral hyperalgesia thing where they inflate a balloon in the rectum. That's about 82%. Volatiles in stool, not available, but 86%. And then look at the first generation markers. So we were able to have some good results, but so if you measure anti-CdtB and anti-Vinculin outside of Gemelli, these are the post-test probabilities you're going to get. About maybe close to 80 for CdtB, only 60 for anti-Vinculin. But when we improved the test, IBS anti-Vinculin is 87, CdtB is 89, and if both are positive, it's 98. The test has been markedly improved by this second generation improvements. Now, today, Gemelli is now offering the test using a blood test at home using Tasso. I don't know if you've seen this device, but you basically peel off a sticker, you stick it on your arm, you press the red button in the middle, and it collects capillary blood. We validated that the blood in the Tasso is exactly the same anti-CdtB and anti-Vinculin levels as if you had taken a puncture of a vein. The test is validated, and now it's on the market in the IBS Smart Kit using Tasso's technology. It just makes it easier. You don't have to worry about phlebotomy anymore. The patient could do this at home. To finish up the story on this before going into SIBO, you can see that there's a beautiful microbiome. You've got all these Campylobacter that suddenly came in and they produce this toxin. As soon as you get exposed to the toxin, you start producing anti-CdtB. But later, about 3 months later, the anti-Vinculin starts to creep up, and that's when the neuropathy occurs, and you get the blue characters, which are the overgrowth. So now let's switch gears and really dig deep on overgrowth in the last 20 minutes or so in the second half of this. This study is a meta-analysis of breath testing in IBS, and you can see in 2020, hands down, it's absolutely clear that if you do a breath test in an IBS patient versus a healthy person, it's more abnormal. It's by a factor of about 8 or 9 times more abnormal. But breath testing is complicated. It really is complicated. And so it's evolving. We continue to try to understand it. And we've added a third gas. So there are 3 principal gases produced in the gut: hydrogen, methane, and hydrogen sulfide. But it's more complicated than that because hydrogen, and this goes back to some of the criticism of IBS and SIBO way back in the 2000s. The breath test doesn't correlate with symptoms. Hydrogen doesn't. So if your hydrogen is over 20 by 90 minutes, you have SIBO and you're symptomatic. The problem is if your hydrogen is 30, which is abnormal and symptomatic, or 100, those patients are no different in terms of symptoms, which is weird, right? You think more hydrogen means more bacterial overgrowth. But the reason is that hydrogen is being used by methanogens 4 to 1. So 4 hydrogens to produce 1 methane, basically sucking the hydrogen out of the environment to make methane. Here, look at hydrogen sulfide, 5 to make 1 hydrogen sulfide. So it's really sucking the hydrogen out. So if you have a normal breath test, but the patient's symptomatic and you don't measure hydrogen sulfide, you don't know. The patient could have hydrogen sulfide. The second thing we've now learned is that hydrogen sulfide causes diarrhea and methane causes constipation. And hydrogen, while it's associated with diarrhea, it's not proportional. The more hydrogen sulfide you have on the breath test, the more severe your diarrhea. The more methane you have on the breath test, the more severe your constipation. So really, these are the 2 outputs that dictate the severity of a person's symptoms as we know it today. We're still learning hydrogen sulfides, brand new. So we're doing a lot of science to continue to understand the cutoffs, the levels. All of these things are going to continue to require more research as we refine our understanding. But I'll get you caught up on where we are today. But even if you did culture of the bowel, it's abnormal in IBS. This is an important study from 2012 because it said, okay, let's take all of our DIBS patients, scope them. What % have SIBO based on culture? It's 60%. So what we know today is that 60% of IBS-D probably, at a minimum anyway, is SIBO. Remember, this is just duodenal samples. So if you did jejunum, you'd get a few more. And if you did LM, you'd get a few more. So at a minimum, 60% of IBS-D is SIBO based on this study. So now I want to just spend 2 seconds talking about the Reimagine study. So we've been doing this now for 3 years. The Reimagine study is basically every patient coming in for upper endoscopy, but not a colonoscopy, is potentially eligible at Cedars to enter the Reimagine study. And what we do here is we collect an aspirate of the small intestine, some biopsies, blood, and a whole bunch of other things to fully and stool to fully characterize the microbiome of patients, but really honing in on the small bowel, because nobody in the world had focused on the small bowel despite tens of thousands of studies on the microbiome. It's all been done based on stool. So the first things first is, and I know this might get into the weeds, and this actually is now published in CGH in August, so I need to update this reference. But if you have SIBO, the microbiome of the small bowel has a lower diversity. If you have SIBO greater than 10 to the 3, that's when it starts. So right here, 10 to the 3. But if you're going to do culture of the small bowel, and maybe most of you don't, but if you are, you use this growth material. You don't use blood agar. You use McConkey agar. Blood agar doesn't discriminate SIBO at all. So forget about blood agar. But there are institutions in the country, big institutions, that do both and add them together, which makes even less sense because some things grow on both. So you're double counting, a lot of problems. But anyways, focus on McConkey agar. But here's what I want to show you. This is super interesting, is that if you look at this side here, so this is a network analysis. This is a normal individual, and no SIBO. And you can see the lines represent the interrelationship between bacteria, and the circles represent the bacteria individually. And the size of the circle is the amount of that particular bacteria. But this is like Los Angeles. You have bakers, plumbers, doctors, lawyers, etc., all in perfect harmony in terms of their distribution in amount. You have the right amount of bakers, the right amount of plumbers, the right amount of doctors, and everything's in harmony. As soon as you cross 10 to the 3, you can see the relationship has changed dramatically. The thickness of the lines are gone. The interrelationships have changed. When you get to 10 to the 5, everything's broken. And I'll show you even more details on why this is happening later. But I want to focus a little bit on this methane story, because we know the bad actor here. We know the smoking gun is Methanobrevibacter smithii, and I'll show you even more data to prove that. But Methanobrevibacter smithii produces methane, and its level in the gut is associated with the amount of methane in the breath, and is associated with the amount of constipation severity you have. So smithii is critical. This just came out, literally. So you're getting hot off the press stuff today. This came out at the ACG meeting about 3 or 4 weeks ago. And it's a meta-analysis of constipation and methane on breath test, and diarrhea on methane on breath test. And you can see where the diamond falls is where it's falling. So this means more methane, more constipation. This means more methane, less diarrhea, because it's on the opposite side. So the point is, if you have methane, you have less diarrhea and more constipation. I know I've already said that, and I've said it a few times, and we know it, and there's lots of papers published on it. But a meta-analysis puts everything in all the papers in one location. Really interesting fact is that as you get older, there's more methane. But because there's an aging conference this weekend, older people have more methane. So is methane good? Does methane help you age better? Or is methane bad? It's a sign of being older and having a different microbiome. We don't know the answer, but methane is more prevalent as you get older. Now I want to talk about hydrogen sulfide a little bit, because this is the new kid on the block. Hydrogen sulfide, again, uses hydrogen. This is one of the organisms, Fusobacterium varium, desulfovibrio, and a number of others are players. But hydrogen sulfide causes diarrhea, urgency, and pain. So let's talk about this new technology with 3 gases. So prior to the Trio Smart breath test, which is what we're talking about today, all you can measure was hydrogen and methane, and you're missing the 3rd gas. Part of the problem with hydrogen sulfide is it's a very reactive chemical. So it can react with materials, it can react with other components in the environment. So you need to be able to figure out a way to create something to transport hydrogen sulfide without affecting its level and that it doesn't react or turn into something else. That's critical. Number 2, you need to reconfigure the instrument completely, the sensors within the instrument, so that it can read accurately hydrogen sulfide, hydrogen, and methane, and not be able to cross-detect by accident. So in other words, the hydrogen sensor shouldn't pick up hydrogen sulfide or methane or vice versa. So the configuration of the sensors needs to be changed. And then you need to validate that the instrument can measure all 3 gases at the same time and be correct to what's in the bag. And then you have to develop the bag that can be stable for 10 days. And then you have to do research on a group of patients to show that hydrogen sulfide is important. So you can see that this is 5 to 7 years of work to get to this point where we are now. But this paper, and I want to introduce this paper in a very specific way. And this is going to sound really weird, but this is actually the first paper in history to validate breath testing, because never has there been a paper where you take symptoms, correlate it with breath testing, correlate it with the microbiome, and back as the full triangle of everything. It's never been done. So this is it. And we published this last year in American Journal of Gastroenterology. So we took patients from need a little copy. So we took patients from an IBS-D trial. This is an FDA trial. This wasn't the SIBO trial. And we took patients from an IBS-C FDA trial. This was a C trial. This wasn't the methane trial. And you can see not all of the C patients had methane. Only about 60 or 70% did. But when they did have methane, they had methane. When they didn't. But more important on this slide is look at the D patients. I always get the question is, I have a D patient and they have methane. Have you ever seen that? If you have a true D patient, look how many have methane. Almost none. If you have methane on the breath test and you have D, you got to be looking for something else in addition to the methane. And that's usually my answer to that question, because what you don't want is to get rid of the methane in that patient, because that diarrhea is going to get worse, as I've suggested. So you have to use the breath test judiciously in your practice for certain very boutique situations. But look at on the hydrogen side. So if you do a breath test, 20 parts per million by 90 minutes is a positive breath test. The average patient who has D is SIBO positive based on that criteria, the North American consensus. But look at the non-methane constipators. They're higher than the methane constipators. That makes sense because I already told you, methane's eating hydrogen. But look at what happened to the hydrogen. It's below SIBO. But if you didn't have the methane, it might have been above SIBO because the methane's eating it up. It's just an example to show you that if you don't measure all 3 gases, you don't understand the story. Hydrogen sulfide is elevated in IBS-D compared to all the other groups. But look at the levels. So 2 may be a better cutoff than the 3. So we started at a higher number. And as we continue to do the science, it's evolving as we're understanding that maybe any level above, maybe even 1.6, we don't know. We're going to be doing a very large study coming up to really dig into, like, where does it tip? Where is it that you're okay up until hydrogen sulfide is X, and then you start to get diarrhea? And we're the research is ongoing. So this is really important. But this is important. Methane, M. smithii. Again, this is the first study to compare symptoms, M. smithii and methane at the same time. And look at the breath test. The higher the I is in the microbiome, the higher the methane levels and the lower the hydrogen levels. I keep saying this over and over again. But when we look at the machinery of the microbiome in the C patient, constipation is driven by methane biosynthesis. And diarrhea, this is interesting. Diarrhea is driven by hydrogen sulfide production. Nothing about hydrogen production here. Hydrogen sulfide was the link. So we're really narrowing it down that hydrogen sulfide is the diarrhea part and methane is the constipation part. So that's where I want to break it down here for you, is that when I showed you the rat study earlier and I said the diarrhea side, the rats went in two directions. The humans do that too. They go in a hydrogen direction, which is diarrhea, but not as bad. And then the hydrogen sulfide direction is two different microtypes. And if you have hydrogen sulfide, the diarrhea is worse. And on the constipation side, there's really only one microtype that's microbiome related that we know of today, and that's the methane and the Methanobrevibacter that we've been talking about. Now, I'm just showing this. I'm not going to show you the details of the paper. This literally got accepted. You can see the final, we submitted it in August. It's accepted. It was accepted in August and it's finally in press today. This week, we finally got the proofs online. And so you can see this is a paper where we gave we gave basically desulfovibrio and fusobacterium to rats, and they got diarrhea. So it's really proving the postulate. We see hydrogen sulfide in humans, it's associated with diarrhea. We see the bacteria in the gut. These are the ones that are associated with hydrogen sulfide and associated with diarrhea. We take those bugs, we put them in rats, the rats get diarrhea. Again, hydrogen sulfide is the key to diarrhea. And then we made methane, we put methane in rats or methane organisms and they got constipated. So let's talk about breath testing and the consensus statements. We started with the North American consensus in 2018 to try and standardize breath testing. The Europeans followed in 2021, and now the Asia Pacific region, including Australia, are in on the 2022 guidelines. But basically, they're all saying the same thing. They agree on the new criteria for SIBO. They agree on the substrates and dosing. And they mostly agree that SIBO and IBS are related. But look at this. This is the first guideline, IBS guideline. So I want you to understand, this is not a SIBO guideline. This is Irritable Bowel Syndrome guideline statement from, again, the Asia Pacific group. Statement 5, IBS patients are more likely to have SIBO. Grade A recommendation. Methane slows the gut and is associated with constipation. Grade B recommendation, but level 1 evidence. And food poisoning causes IBS. This is the first guideline that finally puts everything with all the new data that agrees that everything fits together. And I think that's really important. I'm going to skip this because for the sake of time, I really want to get to this. So this is a finale of my presentation. Then I'll get in a little bit into treatments in the final few minutes. But when we go deeper, now this is the first study in history where we do shotgun sequencing of the small intestinal microbiome in SIBO. And here's what I'm going to show you. Look at SIBO. More than 50% of the entire microbiome in SIBO is just one category, proteobacterium. But it's even more interesting than that. 18% of the whole microbiome is Klebsiella, and 28% is Escherichia coli. This shocked us because you have SIBO, and we always thought it was coliforms, colon bacteria moving up into the small bowel. That's not at all what it is. It's Klebsiella and E. coli. But what I'm going to tell you today is it's not that either. It's E. coli, but K12. So we now think it's not. SIBO boils down to one strain of E. coli. Because look at this strain. It's the predominant strain of E. coli in the SIBO, but it's the one that correlates with bloating, gas, pain, diarrhea, and urgency. And it's a really strong hydrogen producer. So SIBO boils down to like a small handful of characters, with the number one character being E. coli K12. It shocked us. And then the final thing I want to show in this really detailed sort of structural analysis of the small bowel microbiome. I want to show you, because you have K12 and these other cast of characters from the last two slides, look at your ability to ferment. So imagine a healthy person has a 1 horsepower engine to produce gas. Look at the horsepowers of the patient with SIBO, 63 horsepower. They're 63 times higher fermentation potential. So when a patient tells you 10 minutes after they eat, they're getting bloated, yeah, they are, because they're really geared up for fermentation because of the type of bacteria that is so good at fermenting is in that small bowel. And then they have hydrogen sulfide and other weird things I'm not going to get into. But look what happens when E. coli goes up. The higher E. coli is, the more the network breaks down. We've talked about that. The higher Klebsiella is, the more the network breaks down. This is normal. Middle Klebsiella, high Klebsiella, and you can see that the networks really break. Typically, we call E. coli and Klebsiella disruptors because the higher they are, the more they destroy everything in their paths in terms of the microbiome. I've talked a lot about this, and this is the sequence, but then what do, right? We have rifaximin. Rifaximin was FDA approved based on this study in the New England Journal of Medicine as a microbiome therapy for IBS. Although we suspected SIBO, we always thought it was SIBO. We now have a lot more details since the 2011 paper and a lot more details since the FDA approval. But this is important because this got published in 2019, 4 years after FDA approval, that if you do a breath test, you're more likely to respond to rifaximin if it's positive and a lot less likely to respond to rifaximin if that breath test was negative. And of course, if the breath test becomes negative because of rifaximin, 76% of those people responded. So rifaximin does treat SIBO in IBS. On the methane side, it's a little more complicated. Remember, methanogens are not bacteria, they're archaea. Remember, we designed antibiotics for bacteria, not archaea. It turns out we found out through some test tube work that combining these two worked. And in this randomized controlled trial, neomycin and rifaximin was better than neomycin alone for constipation in methane patients. We don't have a lot to go on with hydrogen sulfide. We're learning. We have a new sort of thing we're working on, and it does reduce hydrogen sulfide. It's not ready for prime time yet, so you'll have to stay tuned, but we're working on it. I'll tell you that. But hydrogen sulfide does go down with bismuth, Pepto-Bismol or other bismuth-slate products. So we're doing that in our clinic. So this is how I do it. This is using these tests is how I do it in my clinic. So if I have a chronic diarrhea patient, they all get IBS Smart. I do that for all the patients because if they're anti-vinculin positive, I already know they're going to be a little more difficult to treat. I got to be more ambitious with them. They all get the Trio Smart breath test. If they're hydrogen positive, I give them rifaximin. If they're hydrogen sulfide positive, I give them rifaximin plus bismuth now. And I've had some real wins with hydrogen sulfide. I had a patient where they had multiple breath tests, multiple rounds of rifaximin. And I point to her because I've seen her now a year and a half since the first treatment, and she still hasn't relapsed. So that was shocking to me because she had such bad diarrhea. So I'm not saying none of these hydrogen sulfide patients relapse. I'm saying that I'm gaining experience and some of them are quite dramatic and would never have known without the hydrogen sulfide test. On the constipation, I don't really always do the Trio or IBS Smart because only 25% are positive versus about 60% on the D side. I had a patient yesterday who swears it started from food poisoning, so I do it in them. I ask about food poisoning, but some people don't remember. So I just do this IBS Smart in all my D patients who I suspect have IBS. The 3-gas breath test for the constipation, because hydrogen sulfide can still be there in constipation, especially if methane's present as well, because they can have both together sometimes. But if it's methane, I give rifaximin and neomycin. If methane's negative, then I consider other options. So I started with, this is where we were in 1996, thinking IBS is an anxiety or stress-related disease. And this is the microbiome circa 2023. There's a lot I did not cover here because it's a lot to cover in a 45-minute presentation. But in conclusion, IBS is a small bowel microbiome disease. We now know that. SIBO is an important contributor to IBS, and we now know the cast of characters, and it may boil down to one or two bacteria only causing SIBO. And wow, do they ever ferment? 63 times higher than a normal person, which is shocking. M. smithii is the constipation producer because it produces methane. Hydrogen sulfide is really important. I've showed you that hydrogen sulfide is associated with diarrhea. I've showed you that it's important to measure it because it will change your hydrogen levels. And I've showed you if you give these bugs to rats, they get diarrhea. This is really coming together. And the three gas breath test is the only validated breath test for measuring these three gases. It's been tested in clinical trials and has had a lot of work done. But the work's not over. It's just beginning with hydrogen sulfide. We're still understanding how these three categories of gases and the bacteria that produce them interact because they compete with each other. It's going to be a little bit more complicated in the future, but we're continuing. If you're going to measure anti-CdtB, to be honest, the second generation is validated as better than previous generations. So you really ought to use the second generation test if you want a more accurate, more discerning test. And new drugs are coming. I've been on calls this morning and talking to my research team in the back about some of the new molecules we're working on now for methane and for hydrogen sulfide. So stay tuned, lots coming. So I really appreciate your time and attention, and I'll open it up for questions now.
Hi, everyone. We hope you enjoyed this class. If you're a practitioner, make sure you go sign up at rootbahealth.com. And if you like this video, don't forget to like and subscribe.